ladies and gentlemen, welcome back to Adherent First and 15. Today, I'm very proud to have Ljiljana Jovančević, who is, I've met last year. I was appreciated to join the Back and Rhino Forum last year. So good morning, Ljiljana.
Morning.
Well, so today, Ljiljana she's going to talk about olfaction in neurodegenerative diseases, and I was kind of fascinated by this topic because she will go ahead and she will talk about many different things that usually will not taken care or not taken in consideration when we're approaching to people that can get elderly or people suffering from diseases that we usually see every day in an office. So I will just leave the torch to her, and I keep remind all the people connecting from Facebook, YouTube, on application that the questions should be asked at the end of the talk. Please go ahead with your presentation.
Well, hello everyone. First of all, let me thank briefly Dr. Puya Dehgani for inviting me. I also agree with him that this is a very important topic, and I hope I will convince you all how important this is by this brief lecture. And thank you all for joining us today. So I will start somewhere at the beginning because chemical senses are the oldest of our senses. They have life-preserving role. Olfaction is a chemical warning system with emotional impact, because it warns us of dangers, guide our attention towards hazards, and is important in the regulation of food intake, interpersonal relations, that is social communication. The sense of smell has a major impact on quality of life. Olfactory loss can lead to depression, mood changes, feelings of vulnerability, and difficulties in daily life, like altered food intake, reduced social interaction, and decreased intimacy with a partner. Vulnerability is related to worries and actual experience of safety issues like fire and gas leaks, as well as worries of poor personal hygiene. Olfactory loss, although we have it in 19 to 24% of all adults, and its consequences is underestimated by many clinicians. We are somewhere 40 years behind research in hearing, for example, until only in 2004 is that the sense of smell received the major attention when two North American researchers received the Nobel Prize, named Richard Axel and Linda Buck, for the odorant receptors and the organization of the olfactory system. Since 2004, since are getting much, much better, I mean, meaning research in olfaction. Sorry. Okay. Because I guess there's many people that are not so, that do not know enough about olfaction that would like to start from the beginning or anywhere. I want to recommend you a wonderful book from Professor Antje Welke-Lussen and Thomas Hummel, which is called Management of Smell and Taste Disorders. It's published in 2013. And then from our European Rhinologic Society, a position paper on olfactory dysfunction that has been published in 2017. It has everything relevant and a wonderful set of references that you can use for each and every part of olfactory dysfunction that you actually are interested in. In the end, people who want to be severely updated about olfaction and research into olfaction should follow Clinical Olfactory Working Group. You have a link here. You have a link on the European Rhinologic Society website also. Decreased olfactory function, the risk of it increases with old age and may result from acute and chronic sinonasal disease, upper respiratory infection, toxic chemicals, head trauma, certain drugs, as well as degenerative diseases. We all know that the loss of olfactory function increases with age. It's called presbyosmia. But age-related olfactory dysfunction is more severe in men than in women. So 10% of people older than 65 years have some form of olfactory dysfunction, ranging from mild loss to anosmia, and 62 to 80% older than 80 years. Olfactory dysfunction in neurodegenerative diseases. Olfactory dysfunction is regarded as a clinical correlate of incidental Lewy body disease, Parkinson's disease, dementia with Lewy bodies, idiopathic rapid eye movement, sleep behavior, mild cognitive impairment, and Alzheimer's disease. Pathological protein aggregates seem to affect olfactory regions prior to other regions, suggesting that olfactory system might be particularly vulnerable to neurodegenerative diseases. So an association between neurodegenerative diseases and olfactory impairment is a fact and has high diagnostic significance. However, olfactory dysfunction is usually neglected by physicians. There is considerable variation in the prevalence and magnitude of olfactory dysfunction. So in Alzheimer's, Parkinson's, and Parkinson dementia complex of 1, olfactory dysfunction is severe, whereas it's more moderate in other disorders. Olfactory dysfunction in neurodegenerative diseases can appear early, frequently preceding the motor and cognitive symptoms, being considered a prodromal syndrome, a symptom of some neurodegenerative diseases such as PD and AD. And since Parkinson's and Alzheimer, they carry if I may say, larger socioeconomic burden for patients, families, and the society in general, I will mostly talk about Parkinson's and Alzheimer's. Now, going back a step back into diagnostics of olfactory dysfunction, what we do at first, as usual, we take the history, talking about the onset, course, and nature of the impairment, previous illnesses, medications patients have taken, etc., etc. We do a complete ENT examination, always do a nasal endoscopy to include or exclude a sinonasal cause or olfactory problem, psychophysical testing with validated olfactory tests, which are mostly orthonasal, olfactometry tests, but some centers also use retronasal olfactometry. We do magnetic resonance of the endocranium and olfactory system. Electrophysiological methods at first chemosensory event-related potentials, which also we have in only few centers in Europe, and a referral to a neurologist, particularly in cases of idiopathic olfactory dysfunction. Orthonasal olfactometry is mostly done in Europe by sniffing sticks test. Also, there are other olfactometries. And in the America by OPSIT test. We have screening tests which distinguish between healthy and sick very, very fast. And you can get results in a matter of minutes and are really easy to apply. And then there are more extensive tests, like for sniffing sticks, that is TDI test. This is a sniffing sticks screening test with 12 pens. It's a supra-threshold test. It's an identification test and can be used in children 7 years and above. This is the extended test, which is called TDI, and we get a TDI score. T goes for threshold, D goes for discrimination, and I goes for identification. Using this kind of test, especially TDI, sometimes we can contribute to the localization of the underlying pathology. So if its only ability to discriminate between odors is effective, we can suspect of central nervous impairment. If it's isolated shifting of the olfactory threshold, it tends to indicate peripheral damage. This is the other test, the OPSIT test. You have 4 booklets, all having, each one having 10 odors. It is a scratch and sniff test. And as you can see, there's 4 answers. It's a forced choice test. So you scratch and sniff, and you have to answer 1 of 4. It's just that this OPSIT test goes for 1 patient. It's quite more expensive, and sniffing sticks test can be used for months, for 6 months to 1 year. Okay, during the MRO of the olfactory system, we usually use coronal and axial scans, T2-weighted sequences. We check on the nasal olfactory mucosa. We measure olfactory bulb volume. We measure olfactory sulcus depth and the presence of olfactory tract. OB volume is something very, very important. It is a plastic, OB is a plastic structure that deteriorates when sensory input from peripherally is likely to be decreased. So OB volume correlates with olfactory function. The normal volume is 40 to 60 cubic millimeters, as you can see. Now, the measurements of sulcus depth are usually used when we talk about, when we want to prove congenital anosmia. So we measure then the olfactory sulcus depth. When we refer a patient to a neurologist, what we need? A full cranial nerve and peripheral nervous system examination and tests of memory and cognition. Olfactory dysfunction is an early symptom of neurodegenerative diseases. It's an early warning of the most frequent NDs. As I've said, those are idiopathic Parkinson's disease and Alzheimer's dementia. Many other NDs are accompanied by olfactory dysfunction, but usually not as an early symptom. Focus today is on the potential for olfaction as a biomarker for early or differential diagnosis and prognosis of neurodegenerative diseases. What we could gain from that is that earlier detection of Parkinson's and Alzheimer's would enable testing of potential disease-modifying treatment strategies when pathology is less advanced and treatments may be more effective. So that is the bottom line. Just in few words, a brief reminder about the Alzheimer's. It is the most common neurodegenerative disorder in older individuals, clinically characterized by progressive deterioration in cognitive functions and dementia. It accounts for 60 to 80% of all cases of dementia, with an annual incidence of 1% in persons aged 60 to 70 and 6 to 8% in those aged 85 or more. The prevalence will continue to increase along the longevity of our population. The pathological hallmarks are neuronal loss, accumulation of amyloid beta plaques, phosphorylated tau protein, neurofibrillary tangles, that is NFTs. Parkinson's is the second most common neurodegenerative disorder, affecting about 1% of the population over 60 years of age. The diagnosis is based on the presence of motor symptoms, which are typical for Parkinson's, that is bradykinesia, rigidity, tremor, postural instability, usually manifesting unilaterally or asymmetrically. But also we have several non-motor symptoms that are part of the clinical spectrum, including hyposmia, sleep disturbances, autonomic abnormalities, apathy, pain, cognitive impairment, and ageusia. The main pathologic hallmark of PD is the presence of abnormal intraneural aggregates of so-called Lewy bodies and Lewy neuritis in several structures of the central nervous system. Patients with Alzheimer's and Parkinson's, 85 to 90% of them in the early stages have olfactory impairment, but most are totally unaware of their olfactory loss. Talking about idiopathic Parkinson's disease, olfactory dysfunction is a prominent symptom. Its prevalence goes from 50 to 96%. It has gradual onset. Anosmia is only present in minority. Hyposmia is more common. Parosmia is rare. And patients are unlikely to see any improvement over time. Olfactory dysfunction is often one of the first manifestations of the disease, and it precedes, this is the point, it precedes the appearance of the classical motor symptoms by at least 5 years. So IPD should be considered in at least some cases of idiopathic olfactory dysfunction, particularly in patients who display REM, sleep behavior disorder, or depression. At the time of diagnosis, in newly diagnosed patient, olfactory dysfunction increases the risk of dementia up to 10 years after, regardless of baseline cognitive function. But if you have normal olfaction together with normal cognition at baseline, it predicts a benign cognitive course up to 10 years after diagnosis. In patients found to have a normal olfactory function, the diagnosis, this is the recommendation, the diagnosis of IPD should be reconfirmed or other diagnosis considered. That is how much is this important. The decline of cognitive function in early Parkinson's is more rapid in patients with hyposmia at diagnosis compared to normosmic ones. So a simple smell test may contribute to identify patients at risk of accelerated decline in global cognition, verbal memory, and processing speed within the first 7 years from diagnosis. Also, olfactory dysfunction can help in differential diagnosis because patients with other Parkinsonian syndromes, they do not have as severe olfactory dysfunction as Parkinson's. So it can be a useful biomarker for the disease. Can we use hyposmia to predict patients that are at risk to get Parkinson's or that are pre-symptomatic? Not just using olfaction. Unfortunately, we cannot use olfactory bulb volumes, but we can combine olfaction with other markers of premotor Parkinson's. Jennings and his group, they found that the combination of hyposmia and dopamine transporter imaging deficits may be highly predictive of conversion to Parkinson's disease within 4 years of clinical follow-up. So it has to be a combination. Now we will skip to Alzheimer's disease. Approximately, as I said, 85% of patients with Alzheimer's have olfactory dysfunction. What has been found? Deficit in odor detection, identification ability, recognition, discrimination, long-term odor recognition memory. It has all been seen in Alzheimer's disease. However, odor identification, defined as the ability to identify and name specific odorants and discrimination, are more severely impaired than odor detection. The overall severity of olfactory dysfunction in Alzheimer's is similar to that in PD. However, patients with Parkinson's present more severe impairment of detection threshold. One of the earliest brain regions affected by Alzheimer's is the olfactory system, showing amyloid plaques and NFTs. The olfactory bulb is one of the first areas of the brain to sustain damage in Alzheimer's, as well as brain areas that receive information from the OB, such as the entorhinal cortex. Also, olfactory nerve undergoes early and sequential morphological and signaling alterations that correlate with the development of dementia. So odor identification deficits are an early feature of Alzheimer's and have been shown to predict progression from mild cognitive impairment to Alzheimer's dementia, particularly when you combine them with other biomarkers. And this inability to identify odors correlates with memory decline. In contrast to idiopathic Parkinson's disease, a clear correlation has been demonstrated between the severity of symptoms of Alzheimer's and olfactory performance. And as I said, patients with AD also display MRI signs of OB volume reduction in opposite to Parkinson's at a very early stage. Since this is also the second point, as we said in Parkinson's, the olfactory dysfunction starts at least 5 years prior motor symptoms. Olfactory dysfunction starts more than a decade. That is, pathological process starts in Alzheimer's more than a decade before emergence of other symptoms. So again, a simple, accurate, cost-effective screening tool for preclinical disease is desirable, particularly for treatment and prevention trial design. Now, it is not easy to differentiate whether if it's healthy aging, if it's mild cognitive impairment, or the beginning of Alzheimer's disease. Why is that so? Because the gradual onset and slow progression of Alzheimer's poses a challenge for early differentiation of Alzheimer's disease from other causes of cognitive decline, including healthy aging and mild cognitive impairment. patients with mild cognitive impairment, that's a clinical diagnosis. It was found that baseline odor identification deficit is associated with the 4 times increased risk of conversion to AD. And Conti published a 2-year follow-up study showing that 50%, almost 50% of MCI patients with olfactory impairment and 11% of patients with normal sense of smell eventually developed Alzheimer's disease. So can we use olfaction to detect a subclinical Alzheimer's disease and predict conversion of MCI to AD? Again, we cannot use just olfaction, olfactory tests. We can use the combination of odor identification tests, clinical neuropsychological assessment, and imaging biomarkers. Devanand published a 3-year follow-up study showing that the combination of olfactory function impairment, verbal memory, hippocampus volume, and entorhinal cortex volume have strong predictive value for AD converting from NCI. So we should incorporate olfactory function tests in the assessment of high-risk populations for dementia to screen systematically for subclinical Alzheimer's disease. So olfactory dysfunction, all in all, in Alzheimer's disease may have clinical value as an early diagnostic marker, is associated with disease progression, and can be helpful in the differential diagnosis, for example, of major depression and Alzheimer's disease. Where are we with treatment? This means if we treat Parkinson's, if we treat Alzheimer's with whatever, will olfactory function improve? So far, there are no such studies. So whatever you do, whatever treatment you apply, there will be no improvement in olfactory. Probably no improvement in olfactory function. There is a promising approach if you take olfactory training. And now, what is more important, not just an issue of not getting better olfactory function, but that all patients that have, this is for our colleagues, the neurologists, if we have some listening, that all patients have olfactory dysfunction, that is very dangerous, that they will fail to notice that foodstuffs are spoiled. They cannot detect gas leak or fire, so they must be informed, and their families must be informed that this is that can be very dangerous. Now, since I'm a person that likes references, I like to read. I have to tell you this first, the yellow reference is a wonderful review paper published in 2018, and it has over 300 references. It is practically the basis for my lecture, and I will recommend to everybody who wants to read some more about this problem. And all the other studies, which are very new, so I think this is getting more and more popular and getting more people that want to do research into olfaction in neurodegenerative diseases. So this is my recommendation to you, and I just chose a few of them. For example, this is a first study reporting on age-specific associations of olfactory function and cognitive performance in the general population. It took place in Germany. There was 2,640 participants, and they found out that participants aged 65 to 74 years with olfactory dysfunction showed impaired cognitive performance, and that it was more present in women than men. So they concluded that assessing olfactory function may be an appropriate marker to detect persons at risk of cognitive decline, especially this age group 65 to 74. This wonderful meta-analysis by Jung, published last year, said that olfactory identification is more profoundly impaired in patients with Alzheimer's than in those with mild cognitive impairment. And they suggested that it's okay that we use just a simple test of odor identification. But this is the other study, also published last year, that found out the performance of the odor identification test alone to discriminate between individuals with and without cognitive impairment is limited, so that it's not enough. And they suggested that we need longitudinal studies to show whether and which methods of olfactory testing are suitable to predict the risk of cognitive impairment. So, olfactory dysfunction in neurodegenerative diseases has high prevalence, early presence, persistence throughout disease, and olfactory testing is very easy to be done. So it all has increased interest in use of olfaction dysfunction as a biomarker for early diagnostics, differential diagnostics, and prediction of clinical outcomes in neurodegenerative diseases. So these are my take-home messages. Olfactory dysfunction is common in later life, but also is an early warning of neurodegenerative diseases. So we have to realize there is a potential for olfaction as a biomarker for early or differential diagnosis and prognosis of neurodegenerative diseases. Now, since Dr. Dehgani told me, I can use a few moments to invite you to join us and so we can socialize. I want to invite you all to join us to listen about olfaction and all the other rhinologic topics. In June in Thessaloniki in Greece. It is going to be our European Rhinologic Society meeting, 21st to 25th June, the 28th Congress of the ERS, 39 of the EAACI, and 21st of the International Rhinologic Society. So we are really looking forward to go. It's summer, it's Greece, and it's going to be wonderful. Now, just not to make a confusion, I do come from Serbia, but this is another meeting that I want you to invite you all to. It's also going to be happening in Greece next year. It is our third Balkan Rhino Forum that is going to be organized by Professor Georg Galas, who was one of your faculty, he's one of your faculty, one of your lecturers. So join us at 15th to 17th April 2021 in Athens for the third Balkan Rhino Forum. And now, since I do come from Serbia, and my town Novi Sad is going to be European Capital of Culture next year, I would like to invite you, really all of you, to come and join us for wonderful, it's going to be a wonderful year, all culture, and that is something. I would really like to see you all in Novi Sad in Serbia. And I thank you for your attention.
Brilliant presentation, and I'm always impressed by the amazing numbers of references and how much impact and how much work you've done.
Crazy about references. I do like to read.
I know.
I have to know it all and small details.
But it's very important to keep continuing to go with the references, because once we do have connections at the end, we will finally reach to the whole screen. And you brilliantly presented the differences between all of the diseases and the different manifestation that we come. And also, I'm very fascinated by those connections that could be between, for example, tremor and Parkinson's disease and the early manifestation of those hyposmia. So before going to the questions, which are like more than 20, but we don't have time for all of them, I will leave, please, once again, everyone that has any kind of questions, I will leave the email from Professor Ljiljana so you can contact her directly also. I have an amazing time for the previous Balkan Rhino Forum, which was in Belgrade, and I'm still thankful for the invitation and be part of it. About the ERS meeting in Thessaloniki, please do remind that there is going to be an amazing faculty members and also in ERS juniors specific different how to say mini congresses which everyone can participate. And regarding that, please do remind that there are ERS travel grants provided for younger rhinologists or ENT under 35 years of age, and our association is going also to provide 2 grants for that. So just going ahead with the questions, the first one is coming from Japan, and our colleagues is Chi-Wan that is asking, what should be done in cases where patient is referring for anosmia after influenza?
After what?
After flu.
After flu. Flu goes under post-infectious olfactory loss. They usually have like hyposmia, but a very important thing is that usually they have parosmia as well. So they can smell, but it's never, they do not perceive that smell as the same as it was. 40 to 60% of these patients will eventually go back to normal, to having normal sense of smell. And it's very advisable that you tell them to use olfactory training because it helps a sense of smell to recover. So these patients have the best prognosis of all patients, post-infectious patients. So that is, advise them to use olfactory training. If you want me, I can say a few words about that. Or
Okay. Please, if we have time, I think that we have 20 minutes, so please go ahead. It's important to...
So olfactory training means that you every day tell them for at least 12 weeks. And if it's possible, tell them to use olfactory training for as long as they do not fully recover their sense of smell. So twice a day, they tell them to use 4 smells and to practice. Is it okay? You can still see me. There is rose, eucalyptus, cloves, and lemon. There is also a kit of 4 sniffing sticks that you can buy, also produced by the company that is producing the diagnostic test. And you can practice every day. It's enough to do it for 10 seconds. So twice a day, 10 seconds, 4 smells, and then you will get better results. Your patient will go to a normal, if it will recover, normal olfactory function faster. So just tell them to use olfactory training.
Perfect. So another thing that previously wasn't be referred, so the people can get this take-home message. Another question is coming from Egypt. How can we discriminate hyposmia, cacosmia, or anosmia in patients suffering from Alzheimer's?
How can we discriminate hyposmia, cacosmia, and
anosmia?
Anosmia, how can we discriminate? Well, if you use a screening test, for example, sniffing sticks, I will tell you what are the reference values. If you have identification of 6 or less, it's called functional anosmia. If you have 7 to 11, 7 to 10, it's hyposmia. And if you use, if it's 11 and 12, that is normosmia. So that is, can you see me, Puya?
Can you see me? Yes.
I can't see you, but I hope that you can see me. Okay,
yeah,
now it's fine.
I'm seeing you.
So this is a screening test that you can use with 12 sniffing sticks that can help you discriminate between anosmia, hyposmia, and normosmia. Now that is a quantitative olfactory loss. Cacosmia is something different. It's a perception of smell that is not nice, so a bad smell of whatever you sniff. It will you will perceive it as a bad odor. So it's something different. And I said parosmia is something that is very, very characteristic for post-infectious olfactory loss. Actually, it's a good prognostic sign, especially if it changes during time. If it's steady state, it's not a good prognosis. But I tell my patients, if anything changes, if it goes from, I don't know, roast to fumes to, I don't know, fire, it's good because it's changing and it means that we still have a chance for a total recuperation. So that is like briefly about it. I hope it answers this question.
Perfect. Now the question coming from United Kingdom, the colleague, she's asking, what are the therapeutic options for patients suffering both from Alzheimer and differential sensory smell?
For suffering from Alzheimer and?
And I think that was decreasing sense of smell.
Well, as I've said, there are no therapeutic options for these patients, considering a recovery of olfactory loss. I'm not talking into treating Alzheimer's as a disease, but there is no recommendations of what you can do to recover, to help olfactory loss going back to normal. So what I've said is that you can only use, it's a promising approach to use olfactory training. There is nothing much to it. So we do not expect it to get better over time.
Would you please suggest for younger rhinologists or even immunologists an office-based methods and or would you suggest anything that they can use for testing smells in those patients, please?
You know, first of all, the whole point of this topic that I'm interested in is that you do not forget as ENTs and as neurologists to ask your patients about a sense of smell. That is the first point. If you ask them, you will see a whole world opening to you. You will see how they talk about what is going on, what is happening over time. So you will hear that they have problems. Going from there, you can always start from history and then use some of the screening tests. There are many screening tests, but as I've said, this sniffing sticks test can be used up to 6 months, identification test, or APSIT. Both are there, validated, they are great. So you can use them to see if you can actually get the olfactory impairment diagnosed. Then always you have to do nasal endoscopy to see if there's a sinonasal pathology, being the simplest, for example, polyps, if there are any polyps, or chronic rhinosinusitis without polyps that can cause olfactory problems. And then you know that by treating sinonasal problems, you will treat the olfactory issues. Then after that, if you see nothing, well, if you don't get data about head trauma, about like a flu, like a severe upper respiratory tract infection, if you do not see a sinonasal cause, if you don't get data about some toxic substances or some drugs, many drugs can cause olfactory problems, but you have to read the small inscriptions down and to look for them. And then you are staying with the idiopathic olfactory dysfunction, that is diagnosis per exclusionem. So you have to find, then you have to think about neurodegenerative disease. What I do is I always send patients to see a neurologist to do neuropsychological tests. And then when they do a neuropsychological evaluation of the patient, then we know if there are any suspicion of neurodegenerative disease, and then we go from there. That is where neurologists can take over.
I guess there's another question from Pennsylvania. Our colleagues is asking, is there any correlation between diabetes in advanced stages and decreases sense of smell?
Actually, there is. It is a group of olfactory dysfunctions that are caused by some other systemic diseases. And there, if you treat diabetes, in the beginning, there is a possibility that you get a normal olfaction. But usually, cases of olfactory dysfunction are reserved for patients in advanced diabetes. So as it goes bad, as it decreases, as it goes wrong, that is how olfactory function also will deteriorate. As it deteriorates, the diabetes, the olfactory function will also deteriorate. So there is a connection, definitely.
Another question coming from Russia, and we have just time for 2 other questions. This is very interesting. This question is, can be a therapeutical option for patients suffering from a stroke that are referring from decreases of both sense of taste and smell?
Well, I think this question may be addressed to neurologists more. You have to treat patient that has a stroke the way you do. And then, for example, it would be good to incorporate the tests of olfactory function at the beginning when a patient can do actually those tests, and then follow him up, for example, every month. Usually we follow up patients every 3 months, but in stroke patients, I would do that more frequently and see if we can do, I am all going back to olfactory training. You can also refer and tell them to use olfactory training because it's nothing that can hurt them, definitely. And it will, if it will come back, you can help them with that. So maybe a neurologist should answer a little bit more about stroke patients.
One of the questions that is coming is from India, and I think that this colleague is just enjoying at an advances of your talk. He's asking, can you tell us imaging for the patient suffering from decreased sense of smell? But you already said about the MRI that your algorithm. So. If you have enough time and we can put it once again for him, otherwise I will suggest to just see the recorded that we are going to publish in the YouTube pages.
Yes, I think it's very important for everyone to know that it's not, it's very easy for your radiologist to to take this protocol and to do an MR of the olfactory system in every patient. It's a separate protocol. You know that there's a separate protocol for every imaging. So it's very easy. I got it from Professor Philippe Rambaud from Belgium. And my radiologist said it took him like 15 minutes to do that. So it's not a problem. You should read about, there is a reference beneath my slides, so he can take that to his radiologist and it will be no problem to do that. It's very important. It's very objective. It takes no extra money besides your regular MR that you do in your hospital.
Perfect. So for our colleagues, please, we will publish the whole recording on our YouTube channel, so you will have the possibility to watch it again. Dear Ljiljana, unfortunately, we are out of time because we don't have enough time. But however, I would like once again to compliment you for this brilliant presentation. And I just want the last minutes to stress once again that the talk will be recorded, published in our YouTube channel. There are going to be also a podcast for the people that can now watch that. And I will keep once again in mind that next appointment that we are going to have is going to be February 15th, Saturday, for the ERS Junior panel, which is going to be delivered for a different speaker. We are going to have Alexandra Barac, who she's talking about how to choose the fellowship. Alexandra was one of my colleagues that when I was part of the ERS Junior, and she always took care of me while I was in Belgrade.
She was the president of the ERS Junior.
And then we are going to have Mariana Cherkes. She's going to talk about sinonasal anatomy from the surgeon's perspective. We're going to have Alfonso Santamaria Gadea. He's going to talk about differences of ENT training. And once again, we're going to have Mario Turizazzoni from Castelnuovo School in Varese. He's going to talk about updates in management of epistaxis. We already have a talk about epistaxis with Peter Valenti Tomasic, and then Axel Wolf from the School of Austria. He's going to talk about essentials of sinonasal radiology. Thank you, Ljiljana, for being with us. Thank you for your brilliant presentation.
Thank you, and see you in Thessaloniki and in Athens, in Greece.
Exactly.
Okay. Thank you, Puya, for your invitation, and thank you everybody. Thank you everybody for listening today.
Thank you so much. Ciao, ciao.
Bye bye. Bye bye. See you.